Welcome, everybody. My name is Sharon Pollock, and I am an Escalate TA coach. And it is my pleasure to introduce Allison Jordan to you all as our speaker for today's session. Allison is a leading national public health professional with over 25 years of senior government and system management experience, from procurement and grants to systems change and program evaluation, publication, and dissemination. She led the New York City jail team that developed the evidence-informed transitional care coordination intervention. Passionate about making a difference, this work extended to New York City jail visitors, where she helped create, implement, and evaluate a successful overdose prevention program, distributing 60,000 doses of intranasal naloxone. Allison serves as American Public Health Association governing counselor and liaison to the National Commission on Correctional Health Care, and NCCH representative to the Academy of Correctional Health Professionals. She earned her MSW degree from Hunter College School of Social Work while working as a New York City caseworker in the late 1980s. It is my pleasure to turn this presentation over to Allison.
Thank you much to Sharon and to the team for setting this up. And I see we have 10 attendees so far. And if we can, we'll answer any questions that you have as we go along. What we want to talk about is really how healthcare systems can help be more responsive to people who are coming home after incarceration. I think next slide. Jackie and I worked together on Rikers Island, and then decided that we wanted to help other jurisdictions in our third chapter. So here we are. Opening doors, making a difference is how our consulting firm is really looking to make systems change on the local level. Think, what is it? APHA says think global, act local. So we'd like to do that. Next slide. So today we're going to learn more about why correctional health is public health, is community health. We'll have a framework for you on culturally responsive healthcare, and then what the practice implications are for you and your jurisdictions and your collaborators, with some tools and tips, and then questions from you guys. Next. So we say correctional health is public health often, but we've recently added is community health, because honestly, there is no public health without community health. We saw very clearly during COVID-19 how important primary care was in getting the word out, and how difficult it was because vaccines weren't being implemented in the local level where people tend to access their care. It's vital that for folks, because incarceration really does impact those communities who are poorest and are Black and brown communities, and who have varying degrees of difficulties regarding mental health and substance use and other challenges because of those disparities and inequities over time. The scope is very driven by each jail. Basically, they say if you've been to one jail, you've been to one jail. I would say one jail. If you've been to one jail system, you've only been to one jail, you've still only seen one jail. In Rikers, there were 12 facilities operating at a point in time, and each one has its own personality. And while each of the staff has the same leadership, the reality of how things work on the ground is different every time you go into another building. And really, there's very vital information that's available in correctional health records that would be helpful to linking people to care after incarceration, but very often we find those systems do not coordinate and collaborate. Next. So you can see all of this and more on the Prison Policy Initiative. We are the world's leading incarceration nation. When we speak about decarceration, we're not talking about opening the cells to doors and telling people to go out. In fact, that would not actually even address the problem, because folks would just get rearrested and come back to the facility where, you know, it's the provider of last resort. But what we do need, next slide, is to start thinking about how many people are locked up in the US, where they're locked up, and why. Next slide. And so this structural racism is really underpinning all of the inequities in overrepresenting BIPOC in carceral settings. COVID did not help in any way. And it's all from really preschool and going forward in terms of all the disparities that lead to these challenges that we see in incarceration rates. Next. So we did talk about COVID-19 a little bit at the onset, but there's additional challenges in terms of court fees, paying for phone calls. I found out the other day there's even if you have money on a gift card from a commissary account, the people who give you the gift card are charging fees. And so there seems to be no end to the cycle of creating barriers to people successfully integrating in the community after incarceration. Next. So COVID-19, we know this now well, that the death rates in prisons and jails was 3 times higher than the US population as a whole. Next slide. Not only because of the disparities in the access to care during incarceration, but also because of the folks that are incarcerated are the most likely to be in those population groups that were harder hit generally. So what we're talking about really is reducing the incarcerated population, not only to stem the tide of COVID-19, but to also stem the tide of the challenges that are faced by people of color in poorer communities. Next. So these trends in terms of jails and prisons, you can see there was a downtick at the early onset of COVID, but it did pick right up. And if you look at the more recent data, it's pretty close to pre-pandemic levels in both the jails and the prisons. It takes a little longer for the prisons because those the folks in jail tend to have very short lengths of stay. In Rikers at one time it was about a week. You know, you could average length of stay was about a week, and it's a bimodal system. So half of the folks will be out before a week, and the other half will be out some time in the future, up to 3 years, depending on what's going on with court cases and people with mental illness who try harder to get court dates for and get court resolution cases resolved. And so there's, and then the state rates tend to follow behind the jail ones just because of the timing. Next. So Dr. McDonald said, you know, that the storm was coming and he was ready to fight, but then there were several challenges, including, you know, folks were getting COVID-19, officers were concerned, people with unlimited sick leave were taking sick leave. They had 3, Jackie would tell you, she'll maybe join us later, but she had a daughter who's a correction officer with 3 kids, and Jackie wound up being, you know, school teacher and grandparent and mom and all of it during the pandemic, while her daughter was doing triple shifts and trying to figure out how to have 3 kids and work three tours of work 24 hours straight at a time. So just know that this ballooned from an original call for action that was not heeded well. Next. And really what we're talking about in terms of the folks who are coming home and the ones that we're most concerned about are the sickest folks, geriatric complex care. We have multiple patients, and Dr. Bedard went on the New Yorker magazine and said, you know, the popular misconception is that jails are full of healthy and aggressive young men, but that is very different than the experience that she has working through an infirmary and visiting with her patients. We say that if you have someone who's 50 years old, who's incarcerated and has been involved in that system, they will appear more like a 70 or 75-year-old in terms of their health conditions. Next slide. So these were the folks that we were trying to help move out of carceral settings in New York and others across the country had similar actions to try and reduce the number who had specific health risks, as you can see, the number who had lower safety risks, the number who had technical violations, that is, that they didn't follow the rules for parole and probation. Very often it's a missed appointment. That's the cause of that violation, and then folks stay until the parole hearing is held and something is done. And then there were folks who had been incarcerated for more than 3 years and still hadn't had a trial because the courts had closed. And so we had really the least likely to be rearrested are those who are on violent charges, and then that's counter to what people recommend. So the most likely who are arrested is due to drug use, public order, and property damage, all crimes tend to be related to substance use disorder and mental illness and other mental illness. Next slide. So when we talk about collaborations, who exactly did we reach out to at the height of the onset of the pandemic? Was our collaborators who we'd worked with all along during the creation of transitional care coordination, with housing employment services, with all the systems that are needed in order to work really across disciplines. And the CDC has this nice diagram that really shows all of the connections between public health and community. Next. So we asked the audience what were the key things that people need when they're coming home after incarceration, and that was food, clothing, shelter at the top. Maslow was right. We really don't have to keep proving it. Survival needs, and then access to healthcare and programs and services. And folks may have lost their Medicaid benefits. It can get turned off while you're incarcerated, suspended, depending on your jurisdiction. It may be turned off altogether. That impacts families as well as the incarcerated, because there's no public payer of healthcare during incarceration by an exception under the Social Security law. Next. So we have lots of tools and tips for doing this. It's on the HRSA website as well as our own. And Jackie says it can take one individual to initiate improvement and one team to sustain it. So we're here to give you hope and tools on how to start addressing these challenges in your communities. Next. So we talked about the overdose prevention training. This was with visitors. We found that they have a very high rate of witnessing overdoses. And so if you can get to the visitors in your correctional facility, that's very helpful in terms of finding an audience well suited to opiate overdose prevention training. Next slide. And of course, all of this is really around the social determinants of health. Next slide. So there are many words that are used to speak about the incarcerated population of people with histories of incarceration and people with substance use disorder. We encourage first-person language. This is now the policy of the National Commission on Correctional Health Care as a position statement. Next slide. So what we'd like you to avoid are the words in the middle, and rather use person first language. That would be the ones on in the center. Next slide. Hi. And so there you go. So if you're going to print this out and share it with folks, we encourage you. Sorry, technical difficulty. We encourage you to use the slide that does not have the words on it in the middle. Next slide. Okay. So I really wanted to dive deeper into what is culturally appropriate care in terms of cultural sensitivity, competence and responsiveness, transnationalism, socioeconomic and decide models, and understanding that the goal is to increase healthcare utilization by developing strategies that improve engagement and retention in care for people with incarceration histories, and also understanding as part of those key considerations how really important it is, those first impressions. And so very often you're not the first person in your system to see, you may not be the person, but whoever is the first person to see people coming into your clinic or your healthcare space, wherever your services are being provided, may be a security guard. They may or may not be in a uniform. They may or may not be someone that is treating people who look or smell differently. And so there may be folks who are trying to get people's health insurance card, and it's possible that their public benefits were shut off, and so they'll say, go away, come back tomorrow, and that's the last thing we want for this fragile population. So we really encourage folks to have patient navigators at the door, greet people with maybe the next slide, warm smile and a handshake. Make sure that you're happy to see them, and make sure that message is communicated as soon as possible. We have additional curricula on this through the Spins Latino initiative, and many of the slides here are taken from that. And we did find some great success in improving cultural awareness among populations of people primarily of Puerto Rican ancestry origin was our target population. Next slide. So what is culture? Then folks use these terms like they mean the same thing, and they are all related but very different. So what is cultural sensitivity? We're looking at cultural sensitivity is having a recognition, maybe an awareness, that there are differences between cultures. And if you have, as an audience member, if you think that you know what cultural sensitivity is and that you understand that, would you, if you can you just put your hand up or put a thumbs up or some kind of response so that we can see that you know what culture that you think you understand what that is. Yeah, I'm not seeing any thumbs or fingers or anything. Okay. So if you know what, oh, there we go. Then we got some. And some think that they can do cultural competence in terms of knowledge and understanding of other people's culture. So you're further along in the continuum of this and understand other people's culture, adapting interventions and approaches maybe specific to the culture and family group. And then some of you may really fully understand that being responsive culturally is the ability to not only relate, not only to be aware and not only have knowledge and understanding, but be able to act and respond from relating to people respectfully, not just of your own culture, but from those with other cultures as well. And so it's really gradations. And if you go to the next slide, it ties into the socio-ecological model in terms of looking at the individual, interpersonal, organizational, community, and policy levels, which all need to be impacted. So you can do what you can on your level, but if the security guard says something, uses one of the words in the middle that we don't want to use, all of your good efforts may be down the drain because the person just left the building. Organizationally, similarly, if the forms that you give out say have words or use phrases that are inappropriate, then you can wind up losing the engagement right there. So all of it, and then your policies. Do you have humanizing language policies? Have there been trainings in your organization to understand that saying some of the words in the middle, regardless of the population that you're treating, it could be people with diabetes instead of you saying you're diabetic. So is this being embedded into your organization as a whole? So think about it on all those levels. Next slide. So transnationalism is something that we really worked to demonstrate how a transnational approach could be used. So it's a process by which immigrants forge and sustain multi-stranded relationships. Jackie could join us. She'd be telling you she's a transnational Puerto Rican. The way this looks may sound familiar to many of you. If this sounds familiar, please give us a thumbs up or a handshake or whatever you can do with this here. So if she's on the phone with her mother while she's in Puerto Rico, or if she's on the phone with her mother while she's in New York, either conversation sounds the same. And yeah, that'd be great. Opinions would be terrific. So if she's in New York, or whether she's physically in New York or in Puerto Rico, her relationships remain the same with her family. She's in touch the same amount. She's as actively involved in what's going on with their families, no matter where she's physically placed. And she'll go back and forth in a fluid way to the point where you won't know whether she's with her, whether she's physically there or where she is physically. And that's an emotional connection that happens across distances. Next slide. Yeah, please ask questions and comments also. Welcome. I don't know if I can see them, Sharon. I'm hoping you'll show that for me. So culture.
I'll bring them to your attention.
Oh, great. Thanks.
When they come through. Yep.
So, and then this is just yet another way of looking at these issues around cultural formulation factors that affect your clinical encounters. I think all of these different disciplines are trying to get at the same thing, like when you say the different parts of the elephant, but they're all trying to give frameworks for understanding how cultural formulations are impacted by what happens when you're having a service encounter. So think about the boundaries, cultural boundaries between patients and providers, and assess some of the impact that some of these. So I'm going to ask, I don't know if we haven't asked the audience question yet, is the next slide, but I was going to ask if you could think about what happened, what maybe you'll put in the chat the answers. What do you think happens when the gastroenterologist told one of his, I'm going to say middle-aged male Dominican patient that he was going to schedule him a repeat colonoscopy for January 6th, and then complained vociferously about the fact that he missed that appointment despite the fact that the doctor said how important it was, and the patient smiled and nodded that he would be there for the appointment. Any comments on that? Any thoughts?
Stephen, can you promote everyone to presenter so that they can turn on their video and their audio?
I can't see anybody.
Right. Yep.
And now there's only 7 left.
We're doing that now. We're promoting everyone to
Oh,
present.
okay. Now they're all, I see. Now they've disappeared, but they're good. Oh, great.
And feel free to turn on your audio as well. Can you repeat the question, Allison?
Yeah. So here's a case scenario for you. A gastroenterologist had a male patient in, I'm going to say is early to mid 40s, and he was seeing him and wanted him to come in for a colonoscopy on January 6th. He was of Dominican cultural origin, and he smiled and nodded. And then the doctor, yes, Julia, yes, Julia. Well, he understood and he smiled and nodded. Do we think it's a cultural barrier, or so folks are typing cultural language barrier. So as it turns out, I want to give you all a chance. I don't know who is responding. I saw a couple in the chat.
Yeah, most people are saying that they think it's a language barrier.
A language barrier.
Also,
No,
January 6th, important holiday in his culture.
he didn't understand. So here's the thing. His English was fine. The challenge was that January 6th is Three Kings Day, which is in fact a more holy day than Christmas in some Catholic cultures, Catholic forward cultures. So in Puerto Rico, Dominican Republic, others of similar island and nationalities, January 6th is the highest holy day, and nobody's going to be anywhere except if you are of Dominican origin, you will be in Dominican Republic on January 6th. If you have any money at all to travel, that's where you will be. And so the fact that the doctor took offense to the patient not making it to that appointment, when in fact it was I think on some level part of a responsibility in this communication between a provider and a patient is to really understand their cultural background, and also to know that smiling and nodding is not the same as yes. Next slide. So the DECIDE model is just another way of looking at this in terms of taking action on making things culturally responsive. Decide the problem, explore the questions, closed or open-ended. So rather than saying, I'm making an appointment for you on January 6th, you can say, I'd like you to come in a few weeks. Can you tell me, which time might work best for you? I know the holidays are coming and I don't want to interrupt that, but this is important. And I want to respect your culture and your family, but can you tell me what time and day that will work for you? It's just a different way of having a conversation rather than making a statement, which this doctor happened to be an older white Jewish doctor in a white coat who I'm sure was standing while this patient was sitting. In my mind's eye, that's always the way it is. So if you have direct questions, you know, for your healthcare provider and enjoy a shared solution, that's fine, but it needs to be an open, I think it's on the provider to say, do you have any direct questions for me, rather than to say, you know, teach everybody to say, I want, you know, I have the right to talk to my patient, and we should, right? We should let folks know you have the right to question your provider and to ask, but there's some cultural barriers to that depending on where you're from. Next. So this is more steps on inviting the patient to participate, presenting options, how to go about shared decision-making, facilitating deliberate decision-making, and assisting with implementation. And this is what we're looking for is a collaborative process that gets at what patients and both patients and the provider. So I like the shared decision-making model because it does put the patient's values and preferences into the equation, which isn't necessarily the way that some providers are trained. Next. Simple steps though. So this is our transitional care coordination model. We have components that include a really hard system on the left, which in this case is a jail. It could be a hospital system going to a community clinic. On the right, it could be if you think of any kind of hard, cold, tall, square building with windows and central air conditioning, going out to another hard, cold system with or without central air conditioning, and how you need to make that transition from one to the other. So in our model, what we're talking about is moving from jail-based healthcare services for people with HIV to community-based services for people with HIV. But this can be and has been adapted for people with diabetes, for people with substance use disorder, for geriatric populations, for other populations who are at risk. So, you know, cross out HIV and put in your disease of choice. But the reality is that what we're talking about is really the circle in the middle. And Jackie and I think of this like the 2 hours like a hug. And what we share with folks is that what you want to do is right away, whenever the person enters the system, to start thinking about what are they going to do when they leave, because these tend to be systems that you don't stay long. So the jail is one example, a hospital is another. I'm sure each of you could think of other things, and if you do, please just chat them away, or unmute your camera. And then on the other side of the circle, what you want to do is link people to a system that may be more locally based, but can be just as cold and prickly in terms of, when we talk in kindergarten, they teach you about warm fuzzies and cold prickly. So for us, the two boxes on either side tend to be cold prickly systems, and the circle in the middle is that warm fuzzy that's going to bridge the gap so that you're being able to engage in those care and services in a way that's culturally responsive, that removes stigma and other kinds of barriers to access and care. So whatever the barriers are, those are the things you want to remove. In this case, it was health insurance, health information. It could be housing. There's always housing challenges across this population continuously. Employment, access to employment, training, all those kinds of systems. So you see, we document linkages to primary care, substance use. As you can see, this slide predates the humanizing language, and so it's a brick now. But know that going forward, we use our humanizing language and linkages to those services after incarceration. Any questions about this model, because it's kind of key?
I just have a general question, Allison.
Yeah.
Can you hear me?
Yes.
Okay. What are specific strategies to be culturally sensitive to this population? Like what does that practically mean?
Right. So go to the next slide. So some of it is really simple, right? Instead of your address, ask, you know, how can I reach you? Where do you sleep? What way would you like me to speak with you? Keep it simple, right? Make sure that there's be cognizant of the differences and just ask folks. I mean, you look at that decision support tool. is there a way I can reach you? Now, very often we won't ask people what their phone number is. We'll ask them how to reach you because we don't know what phone they're going to have when they release. The phone number, it could be on a burner phone. It may not. And so one answer I got to that question, how can I reach you, was, well, take my phone number. I'm like, your phone number is not going to work. You have a burner phone, and when you leave, you're going to get another one, and I'm not going to be able to reach you. So tell me the real way I can reach you. And he said, well, I always call my mom on Sunday night. And so here's my mom's number. And if you call her and leave a message for me, I'll call you back on Monday. So don't assume that people addresses are the most, I mean, when we were doing Medicaid applications for folks, you had to list every last known name and address. And we're talking about 3 pages of 10 font for one person in terms of names and addresses. So these challenges of the simplest things in terms of that. What was that? Oh, there's so many examples. Let's go to the next slide and see if I come up with another one. Keep it simple. The body language. Honestly, people know in a blink, so it really isn't a matter of asking questions. And I'd like you to think about, so this is what, I don't know, more or less clinics look like in my estimation. And so if you tell people to have a seat, take a chair, go to the next slide for me. Sometimes it comes up. This is what the last time someone told them to take a seat in a chair in a clinic looked like. So they may have been cuffed hand and foot to a pole. There may not have been people with, there were likely people with some kind of weapons who were escorting them to the clinic, who were telling them to sit in a way that was neither that was cold and prickly. They had to go through bars to get there, several sets of bars, gates opening and closing, buzzers coming and going. It's loud. There's no peaceful music going on. And then you walk into a place that's probably a little bit cleaner than the rest of the jail facility. But the reality is when you go to see the doctor in a jail setting, there's a lot of trauma associated with actually just even getting to sit face to face with a provider. And then you're hoping that that provider has received this training. Which I can tell you which 20 jails have had this training, and all the rest have not. So just know that this is a traumatizing thing for people to go to a clinic and to be seen in a correctional facility, and that may have been the last experience. I'm hoping I'm getting to your question. You want to go to the next slide? So if you're going to be having a trauma-informed approach, you want to make sure that the person is safe, their well-being, that they're not sleeping on the street, that they have a place to live, that they had a meal, that you're being trustworthy and transparent, that you're not being judgmental. Very often we'll use peers. We did a lot of training of peer educators, and very often we'll encourage that patient navigators either are peer leaders or work with peer leaders, so that that experiential learning becomes part of your team, and then they can kind of transfer the juice a little bit to you. And just, what's important to you needs to be what's important to the client. I was very famous for making very good discharge plans that the courts and judges and DAs all signed off on, but they weren't the plans that the client was going to keep. It was the one they were going to sign, but it wasn't the one they were going to keep. And so they failed, right? So I can convince a judge and I can convince a client to sign off on a discharge plan that looks like perfect, but perfect plans are never executed, right? Because there's no perfect people and the plan does not work the way that it was. So Jackie would give a plan. Is her discharge plan, I don't know if you can see my little laptop screen. Jackie's discharge planning form looks like this. Can you see this? This is a blank sheet of paper. She puts it in front of the client. She says, what's your wish list? And then she'll have the client can't read or write, or the client doesn't want to write, or for whatever reason, they're not interested in writing. She'll say, well, just tell me. And then she'll write it down because you don't know what the literacy level is. And so they'll say, well, I want this and I want to do this and I need a job with benefits and all these things. So, okay, you need a job. And then she'll start helping them prioritize, really using motivational interviewing techniques, but doing it really begin where the client is, right? So the client is, you don't know where the client is, ask them. And then make sure that their voice and choice may not be the one that you want, honestly. It happens that folks don't necessarily want the perfect path to the way life is. They have different priorities. One of our clients told me they had to feed the dog before they went to the treatment program. We don't need to discuss here what feed the dog meant. I thought there was a furry animal. There was not a furry animal, but nevertheless, the dog had to be fed. So the navigator was told to make sure that they took the person to the appointment so they could feed the dog, and then they would take them to the next place on their journey. Now we have programs in New York where you can feed the dog in a safe place that the federal government may close one day, but in New York City they leave syringe access available. So whatever it is that the client needs in order to get to the next step, and do it in a cultural responsive way, and empower them to get to what it is they need for their health and well-being on their terms and not yours. Next slide. So when you're working with those cold prickly systems, it's really important that you understand the culture of the cold and prickly system, of the folks who are working on the inside, and to demonstrate, to the extent that you are trying to coordinate care with them, that you understand that their day is tough. That and we've always said, like, we ran peer educator training classes in the jails, and we always expected to give more than we received. Never mind something for nothing. It's always going to be that what you are able to do has to be delivered and then some. So I would say under promise and over deliver always. And then acknowledge the burden on them in trying to help you coordinate care from that cold prickly system into on the left to the maybe less cold but still prickly system on the right. Show that you're cheerful, accessible. We would bring donuts. We would go to Jackie says she went to every shower, every graduation, every event for people's children. She was always cheerful, smile. She would always compliment people first before when working with the correction staff. Go to the next slide. You get the idea. Miss Mary Sunshine, knowing the chain of command in one of those cold systems is really helpful, because you could be working with someone and you think, oh, I talked to the commissioner and that's all going to be well and good. But in New York City jails, you can talk to the commissioner all day long, but you're not going to get a program in place unless you're dealing with the deputy warden for programs. So know your environment, know who you would talk to, ask about, how could we interview people if they're in this cold prickly system and we want to bring them to one on the outside? What would that look like? Next. So this video, I want to leave time for questions. You can listen to it. Basically, this shows you the day in the life of a correction officer. This is trying to get empathy for folks who work in these systems, because we're not, how would I say, we don't want anyone to have to go through what folks go through in these really torture chambers, and it's not pleasant for anyone who's in there. And there are better ways. There's better models. We know what they are. Norway has lots of good examples, but really it's about treating people the way that you would want your family treated if they were incarcerated. I feel like I have another slide to go. Did we keep going? Oh, there we go. So these are the kinds of things that interfere for the health staff and for the people who are incarcerated. Getting sleep. I mean, I had one guy with a seizure disorder who wouldn't take his seizure disorder medication because it made him drowsy, and he wanted to be awake at night because that's when the trouble started, because that was when there were less staff around. And so he was deliberately not taking his seizure disorder medication because he was afraid to sleep at night. So you just don't know. I mean, searches, we would give out up to 3 wrapped condoms for people theoretically to use after incarceration. We were in a don't ask, don't tell mode on that, because having sex in jail is against the law. Apparently, no one who's incarcerated can have consensual sex, which was really designed to protect them from, I think, more the staff than the other incarcerated folks, but it stays, and that's why we have Prison Rape Elimination Act. There's a lot of difficult things that happen, but we wanted people to feel safe, and it's very challenging when you go into a jail facility to make sure that you're safe and know that the folks who were coming home were traumatized before they got there, and that trauma was just expanded upon every day sequentially, and that the populations that are being trauma that are most impacted by trauma in terms of racism, which is just serial trauma, and traumatic brain injury go hand in glove. People who are incarcerated have much higher rates than even football players for traumatic brain injury because of some of the violence in the way that it happens in correctional facilities. Next slide. So I was hoping this was going to be in my original view of this, you just block out the column on the right. But so we we asked correction officers, it was part of a human rights survey that we did of correctional health providers, what did they, as a correctional health provider, do what would they do if a trans woman, this is a real example, living with HIV, housed in a facility for men at the time. Now the trans women in New York City jails are in female facilities if they want to be. Tells her doctor in the jail that she's having unprotected sex in the housing area with those she's interested in. She was very this is a specific client I had in mind, and she makes me smile still, God rest her soul. So she asked for a condom. So the question, the DOC rule is that you can have 3 wrapped condoms in terms of their protocol on your person. So do you just hand the person 3 wrapped condoms as the protocol allows? Do you put a box of condoms in a drawer and just open the drawer? It's my preferred approach. Do you never provide condoms to incarcerated people? It's just not worth the grief from DOC. Or do you report the patient for security violations for having sex while incarcerated? And almost over a quarter of our correctional health providers thought that that was the right answer. I cannot tell you whether they thought it was the right answer because that's what they would do, or if they thought that was the right answer because of their environment. Because I can tell you, I can't think of one time that a person was reported to security for having sex while incarcerated by a correctional health provider, but nonetheless, with the dual loyalty implications of working in such a setting, almost more than a quarter of the providers that were surveyed thought that that might be the answer we were looking for. Wild stuff. Any comments on that? Does it just, I mean, it's just, yeah. So this is the setting that folks are receiving healthcare in. This is not the correction folks. This is the correctional health providers, the doctors and nurses that are taking care of people while they're incarcerated. Any comment? I'm not seeing anything. Or hands, I can't see any of that.
Feel free to turn on your video and unmute yourself.
And or unmute. Terrell is not surprised. We'll go to the next slide. So when we're talking about, you can see how stigma is embedded in all of this cultural responsiveness. So understanding, on the inside, what self-determination looks like is come when I call you, do as you're told. You're constantly in a state of uncertainty. You're on high alert all the time. You don't know when there's going to be pepper spray, when a fight's going to break out, whether you're going to be able to access the rest facilities in any kind of private way. And then outside, we say you're responsible for taking care of all of this yourself, keep your appointments, navigate the system, manage. So everybody, you're dealing with a population that's been told not to think for themselves and to do as they're told, and then you're expecting them to be self-sufficient and manage their lives without any skills necessarily to do that. So, and then remember that folks who that have a history of incarceration were likely chained in chairs, were called the I word, were potentially outed, maybe intentionally, maybe unintentionally, for their illnesses. Like, you know, we all know about the red dots on charts for people with HIV. They have to stop doing that. Or even just, you know, having pejorative terms for people living with HIV that are really known to folks, right? Both inside and out. Missing meals. And so it's potential that if you go to the clinic when you're called, then in its mealtime, that when you get back to the housing area, there's not, your meal's not going to be there. So you have to choose between waiting, going to the clinic, or missing a meal. Other unknowns, like you don't know when, people don't know if they're incarcerated in jail. They don't know if they're going to stay or they're going to go, and when their next court date's going to be, what's going to happen at that next court date, and who is going to meet them at when they leave, where they're going to be met, when that's going to happen. No one knows that information. People are woken in the middle of the night and in not the most kind and loving way to go to the hospital for some kind of procedure, and they're not allowed to know when for security reasons. So 4 o'clock in the morning, somebody kicks my cot, I may roll over and tell him, no, I'm not going to, you know, get my colonoscopy tonight. So people are confined in bars and in pens in the health clinics. So there's cages, literally cages for human beings who are stacked on top of each other, and they're held there while they're waiting to see the provider. Their insurance is turned off, their income is gone, and their housing may or may not be based on their preferences, but it could well be based on their physical presentation. There's we aim for audio privacy. Visual privacy is not I was in one facility where visual privacy was allowed, and that was in Hampton County, Massachusetts, and the doctors insisted that they be able to see their patients behind a closed door. That is not the norm in most facilities. I've seen people get blood pressure cuffs through, you know, in TV you see those when people make a phone call and then there's a glass partition and then there's like a little slot in between where you can slide a piece of mail or something. I've seen people get their blood pressure tested by putting their arm through a slot like that, and that was in Baltimore. So just know that the way that people are treated during incarceration is traumatizing the entire time. And so all of that is going to impact their ability to do the things that are expected of maybe you or I are able to manage, but they may or may not be able to because of really not having the tools in their toolbox and having all these competing, overlapping traumas. Next slide. We're getting close. So Jackie says it is critical to working with incarcerated people is to understand that they have all these critical, competing, compelling priorities. So if you think about the person who's coming home, they have to communicate, negotiate, advise, oversee, provide, assist, maintain, and support all of this at the same time with hospitals, insurers, corrections, follow up with parole officer. The health department may have a survey they want to do, parole courts, community health workers. The list of the network is knowable, right? We look back at the slide where we were looking at where public health intersects, all those different organizations, that patient has to navigate each of those systems. And so if we don't have a coordinated approach or navigation or supports or peer leaders, it's going to be challenging. And what happens is that one of those things gets missed and somebody's traveling an hour after curfew or whatever it is, and then they wind up reincarcerated. So all of this is connected and really needs to be managed by the programs that are serving people coming home after incarceration in order to meet the needs of the people coming home. Next. So we want you to remove those barriers. And once upon a time, this chess piece guy was able to push the barriers off the slide when we have animation. So just imagine that happening. But you know, hierarchy of needs. Maslow is not wrong, and we know what has to be done. The question is, can we do it? We would offer personal care items. You'll see on the Bombas commercial that socks are number one, and then followed by underwear and t-shirts. Warm beverage is always nice, even on a hot day. Maybe some ice water, but remember that if you ask someone to sit in chairs, they may not be inclined to wait. So we like to have. So here's something. I don't know if this will ever happen at any clinic, but I pitch it out there just in the event that some of you may one day have the opportunity. So imagine if you're in, have any of you been into an amusement park, at Disney World or Universal? It doesn't matter, even the local one. Where has anybody done that? I really can't see anybody. I know you're there.
Yeah, videos aren't on.
The videos aren't on, but
Yeah, people can turn their video on. But wait, people are raising their hands, so.
cool. So yeah, so you've seen, so you go, so imagine this. There are no chairs when you're waiting. You might wait for 45 minutes to an hour. In fact, they'll tell you how long you're going to wait, but there's no chairs in Disney World or in Universal for you to sit and wait online. The Harry Potter ride is my personal favorite. So they have an exhibit that you can actually do without the ride at the end, which I preferred because there's a certain gyration that happens in that ride that didn't sit well with my central nervous system. But you can go through, and while you're online, something pops out. Sleeping Myrtle comes and she gives a show. You go in and there's this whole animatronic thing going on, and they have the Sorting Hat. You go now another few feet and something else happens. You're being entertained the whole time. So I saw a clinic do this in East New York. It was one of the Health and Hospitals clinics. Because I went in and there was no one waiting in chairs. And I said, how is that you did this? And essentially, she used amusement park method. So she had a little conference room. During COVID, all this gets more complicated. A little area. You could actually leave the chairs there, but run it like a group health education session on diabetes. Diabetes worked because everybody even if you don't have diabetes, everybody in America knows somebody with diabetes. And so she said, hey, you want to know more about diabetes? Maybe you'll listen in, and then when we're ready for you, we'll let you know. So there's a session going on all the time, health education around diabetes. You can pick some other disease. It doesn't actually matter what you talk about, so long as you make it engaging the person and not telling them that you're more important than they are by telling them to have a seat and wait for you because your time's more valuable. So, and then she had a system where it was color coded, which might not work for folks that are color limited, but essentially everybody had to finish the rainbow before they could leave, but it didn't matter what order they did it in. So if the main event, I think like the ride is the main event, like seeing the provider is the main event. But if the main event is at the end of the line because they're the busiest people with the least amount of time, then you might get your blood pressure checked, you might get blood work done, you might have someone talk with you about where do you get your medication. That doesn't have to be done at always the same time in the same order that the clinic decides. You could do it based on who's available to see whom and do it in an organized way, and then that way you're actually being responsive and reducing stigma and addressing the kinds of issues that are faced by people who are faced with trauma just from the fact of you asking them to have a seat. And really, aren't you just right sizing a relationship that currently exists that says that this hierarchical patriarchal system, you're putting the patient first. So data sharing, creating single points of accountability, having walk-in hours, all of these are different ways of removing those barriers. Pretend the chess guy just moved off the page. Next. So we say removing barriers and establishing relationships. So you want to listen first and then ask good questions. Use a blank piece of paper. You don't have to sit there with your form looking at the desktop and then looking at the patient and looking at the form. Just write it down on a piece of paper. Go to your computer, see if you have all the information. If anything's missing, say, just let me check my computer and say, I've had so many folks interview me with their back toward me because they're looking at their screen. This is not a way to engage people. This is not establishing relationships, and this isn't listening first. This is getting what I need done because my system and my work is more important than you and your needs. We need to right size this in our clinics. Next one. Yeah, don't let go, by the way. Once they're with you, please don't go. I have stories about, you can go back actually just for a second, to the one above. Yeah. I mean, I had a client who was hungry, and his mother called me and told me where he'd be, and he was living in his car. And she said he really needs food. So I said, well, let's go. I'll meet him, and we can go over to the public assistance office, and I can get him emergency food coupon, voucher for the weekend, and I could get him a place to sleep. She says, no, he wants to sleep in his car, but I'm really worried he's hungry. He looks so thin. So I went with him. He met me, which was that was hard. It was only because his mother, I said, your mom really is worried about you. Can you do this for her? So I promised your mom I would help you, is what I said. And then I sat with him, and we went through, I mean, it took hours for them to write this check. I think the process is simpler now, but hours to get this emergency check. And then we were going to have to go to a check cashing place, and he was going to have ID, and I was going to walk with him through that. But I do not have the strongest bladder, and I had to use the bathroom. And we were at the point where they were printing the check, and it was going to come, and then I was going to go with him to the check cashing place, and I'm not going to make it. And while I was in the restroom, he bolted, and I never saw him again. His mother hadn't heard from him again. I don't know what happened. So I tell staff to make sure that they have taken care of their business and make sure that you don't let go. So it's just real. It's what happens. Next. So we have lots of resources for you. The day in the life, a 3-dimensional plan. There's an entire curriculum on this. There's a whole webinar that you can view that Vincent Guillermo Ramos did on the cultural appropriateness stuff, all that background information we were talking about at the top of the slide deck. And then the handbook is really just a nice way of getting introduced to some of these topics. The language matters. All those blogs are available on the internet, and I would love to hear questions from you guys.
Actually, we're at 3:01 right now.
Oh, we did it.
Yeah.
Well, thank you so much, all of you, for attending. Just know that we are very reachable and available in all of the work that we've published, and I appreciate you staying on. And if anybody did want to connect with us, just send us a quick email at Ali@acoja consulting.com. ALI.
Everyone's going to get the deck, so they'll have your
there you
contact.
go. So you'll have all of the resources to
Yes.
list. Thank you so much.
Thank you so much, Allison, and thank you all for joining today's office hours. Stay on a minute, Allison.
Yep.
Okay, great.
And then there was 6. Well.
Thank you. It's just the 3 of us now. Well, that was a good save there, Allison.
Which part?
Just getting on.